distinguished parliamentarians, honored guests, colleagues, and friends, I extend a warm welcome to all members of Parliament present with us today. We are especially honored by the presence of the Right Honourable the Baroness May of Maidenhead, former Prime Minister of the United Kingdom, whose lifelong commitment to public service and leadership lends great significance to this forum. Distinguished parliamentarians, honoured guests, friends, it is my privilege to welcome you to Malta for this important forum of the Parliamentary Diabetics Global Network. We are gathered here not only to speak of diabetes, but to confront the hard truth. This is a crisis we have long understood, yet too often fail to act upon. According to the International Diabetics Federation, more than 540 million adults live with diabetes today. By 2030, this number is projected to rise to 643 million. And by 2045, to nearly 800 million. These are not statistics. They are lives. They are families, workers, children, elders. So behind every number is someone who will lose either eyesight, a limb, or their independence, simply because action was too late. According to the same International Diabetes Federation, more than 49,000 in Malta are living with diabetes today. This is about 10% of the adult population. The Saħtek Health Examination Survey, Saħtek in Maltese means your health, revealed that nearly 4 in 10 cases were undiagnosed, and this is a silent threat. And the red light is flashing before us. Here in Malta alone, type 1 diabetes cases have risen from 829 in 2023 to nearly 2,000 today. That is more than doubling in just 2 years. Type 2 diabetes has surged from 20,632 cases 2 years ago, 2023, to over 39,000 today. That is an increase of almost 90% in barely 24 months. So this is not a slow-moving epidemic. It is, in my opinion, an accelerating crisis. These are not abstract numbers. They are proof that the crisis is real, it is growing, and it demands urgent action. We know what must be done, of course. Early detection and education are the fulcrum of prevention. Too many discover the condition only when complications set in. Screening must be universal, accessible, and continuous. Education must start in schools, extend into workplaces, and reach families everywhere. This is not optional. It is the first line of defense. But let us be honest. Education is not enough. If we tolerate an infrastructure that poisons people while profiting from their suffering, for example, what drives diabetes is not only genetics, but also the symptoms around us, food and drink, saturated with sugar and salt, stress-filled workplaces that push the body beyond their limits, industries that package disease in this disguise of pleasure. So I quote the World Health Organization that urges countries to tax sugar-sweetened beverages to reduce consumption and lower obesity and diabetes risk. Evidence links ultra-processed foods with higher type 2 diabetic risk. The World Health Organization, together with the ILO, International Labour Organization, joint research shows that working 55 hours or more per week increases the risk of stroke by 35%. And ischemic heart disease by 17%. We cannot pretend we do not know. These are facts. We do know, and therefore, failure to act is our negligence. So let us be clear. If stress deliberately inflicted by management or co-workers leads to illness, there must be accountability. Where responsibility is proven, legal consequences should follow. Health is a right. It is not a privilege. And rights demand protection. If products are scientifically shown to cause harm, they must be regulated, not glamorized, not marketed to children, and not sold freely as if they are, or if they are harmless. The European Union, for example, must lead by restricting or banning such imports, so that the food system itself is reshaped towards health, not disease, and so do others. Here in Malta, our main hospital, Mater Dei, has completely removed sugary drinks, high sugar foods, and other unhealthy yet much desired items from its public canteens, setting a higher standard that most hospitals across Europe, where such products are merely limited or taxed. We are leading by example, for sure. It sends a powerful message. The places devoted to healing must also lead by example in prevention. Well, we say it is a small measure, but it sends in itself a powerful message. Unhealthy products should not be normalized in places of healing. If Malta can begin, definitely Europe can follow. And the world, I would say, can learn. Yet much remains undone. And the national figures I cited a few moments ago should be a call to conscience. Between 2023 and 2025 alone, Malta has witnessed, as I said, an almost doubling of both type 1 and type 2 cases. This is the price of delay. This is what happens when words are not matched with enforcement. What has been done, we have global awareness campaigns, we have research, of course, we have individual champions. What has not been done, we have not held industries to account. We have not built safeguards into our workplaces. And we have not integrated mental health and workplace well-being into our prevention strategies. What must be done, we must legislate, regulate, and prosecute where necessary. We must make the healthy choice the easy choice, not the most expensive, not the least accessible. Today, we are, and I am pleased, have the honor to have with us, which certainly will inspire us to persist, the Right Honourable Baroness May of Maidenhead, former Prime Minister of the United Kingdom, Theresa May, which will be recognized here in Malta with the Global Parliamentary Advocates Award. And we are very honored that it is going to happen this here in the Parliament of Malta. Of course, her lifelong commitment to raising awareness and influencing policy has shown that politics, when guided by conviction, can save lives. Malta is very proud to welcome you, Baroness May, for this occasion. Thank you very much. Colleagues, we cannot afford complacency. Diabetes is preventable in many cases, manageable in most, but devastating if ignored. Life is not token to play at the casino. Life is a sacred gift from God. Our purpose as legislators is to serve and protect, to ensure that no life, not even one, is lost because the system failed. Let this forum here in Malta mark a turning point from education to enforcement, from knowledge to accountability, from speeches to action. Together, let us commit to a world where fewer children inherit a lifetime of illness, where fewer families grieve preventable loss, and where health is safeguarded by the courage of those elected to serve. That is our duty, that is our responsibility, and that must be our legacy. I thank you very much. Thank you. Now, before we proceed our meeting today, I would like to share with you some house rules, of course, to make sure the forum moves smoothly. First of all, I will introduce each speaker according to the agenda in front of us. The speaker will be invited to stand up for the intervention, so that the camera, because we are live on TV, on Parliament TV, the camera is centralized accordingly, and one of our ushers will place the lectern in front of you, and the button speak should be pressed from the console in front of you, so that the microphone is switched on, and of course the camera is focused on the speaker. This is for our distinguished guests also during our discussion. On the same note, if you are not speaking, kindly do not press the speaking button. All the speakers must respect the time allocation that you have for the speeches. I will keep the time limit for everyone because we have the program that has to be fit in accordingly, and a green light, which you will see there. When I switch that on, I mean, the members of Parliament all know what's the reason of that. That will mean that you have the final 2-3 minutes to conclude. If the time up, of course, I will put on the red light. Persons sitting on the strangers gallery, please, you are not allowed to take photos or should wait for the official photograph, which will have also official photograph later on. Thank you very much. So we can move, and I now ask Sir Michael Hurst to make his opening speech.
Mr. Speaker, may I, on behalf of PDGN and the parliamentarians from all over the world, thank you for the invitation to come here today and hold our first session in this remarkable Parliament. When Chris and I came to see you earlier this year, I had an image of a Parliament full of members of Parliament who championed diabetes, with a guest of honour in Baroness May, somebody who has real-life experience of living with diabetes. And I have to say that my hopes and expectations have been completely fulfilled. I thank you for the warmth of your welcome and for the fact that you were so ready to put the Parliament at our disposal and invite us here. Parliamentarians have come from many parts of the world. Australia, I think, is probably the longest distance to come here, but I know that people have travelled during the night. They've travelled amid difficulties, like Maxim and Kirill from Ukraine, and I'm really, really delighted that they have shown that commitment to come and join us here today. Diabetes is, as the speaker has rightly said, a huge challenge. And therefore it is a wonderful thing that we have later today a presentation of the first global award to a parliamentary champion in diabetes. And Baroness May is a most deserving winner of that award. And we look forward to hearing from her later, but also to hear about her journey in diabetes. You have achieved a huge amount by being so open about having diabetes. That has done enormously positive things to normalize diabetes in the minds of people. But last night we heard the eloquence of the High Commissioner talking about the admiration of Baroness May's staff when she was Prime Minister, how she, in a calm and disciplined way, lived with the challenges of living with diabetes. And she was a Prime Minister during a turbulent time of British politics, as we know. I think it's fantastic that she has achieved what she has, and I look forward to hearing about her journey in diabetes. But can I just say that she's not the first Lady Prime Minister to have championed diabetes. When I was in the House, Margaret Thatcher was the Prime Minister, and that was where my journey as a diabetes advocate started. I went to see her to talk about the need for disposable syringes and blood glucose monitoring to be available for people with diabetes. And she listened patiently and challenged and made inquiries and then forced the Treasury to find the additional money to improve the lives of people with diabetes. I little thought that meeting that I had with her was to start what was a lifetime of diabetes advocacy. But today, we're especially pleased that we have Baroness May and like everyone else here, look forward to hearing about her journey. Thank you, Mr. Speaker.
Thank you very much, Sir Michael. Now I ask Right Honourable Baroness May of Maidenhead, Theresa May, the former Prime Minister of UK, to make her own presentation.
Thank you very much, Mr. Speaker. I have to say, for those of you who have been in the House of Commons, you will understand this. For those of you who have not, I think these movable chairs are a very good idea. Because unlike the benches of the House of Commons, it means you're unlikely to fall asleep in them. Mr. Speaker, thank you very much for your introduction. Sir Michael, thank you for your kind comments in relation to me. But may I add my thanks as a parliamentarian to you, Mr. Speaker, for enabling this group to meet here in the Parliament, which is entirely appropriate, as it is a network of parliamentarians, and talking about the difference that parliamentarians particularly can make in advocating for those with diabetes. I've been asked, as you've heard, to talk a little bit about my own journey through diabetes. I have a confession to make. When I was sitting with the consultant at the Royal Berkshire Hospital in Reading, and he told me that I had type 1 diabetes, my immediate reaction was to say to him, remember he was a consultant with decades of experience in diabetes, I looked at him and I said, I can't be. I'm too old. Because I thought that diabetes was something that was always diagnosed when somebody was young. But of course, as we know, it is something that can happen at any time of your life. I learnt that lesson. But of course, I had actually been diagnosed initially with type 2 diabetes. 2012 was an important year for the United Kingdom. It was the year in which we hosted the London Olympics and Paralympics. At the time, I was the Home Secretary, the Interior Minister. I was personally responsible for the security of the Olympics and Paralympics. Despite actually knowing the symptoms of diabetes, when I started to lose weight, became tired, was constantly thirsty, and so on, actually I just thought it was the stress of that year. And that's why I think it's so important that we try to make sure that more people actually understand the symptoms, and if they have any of the symptoms, then they ask the question of their doctors. Because in a sense, it was luck that meant that I was actually diagnosed. As it happens, my husband Philip had been ill and was diagnosed as having a dose of bronchitis. And then I got a very bad cough and chest and so forth and went to my GP, and she wasn't sure, so she took a blood test. And I remember sitting in my office in the Home Office and getting this phone call from my GP, from my doctor. And when you get a personal phone call from your doctor, you start to worry about it. So I took the phone call, and she just said, the blood results have come back, you're diabetic. Just like that. Come in and see, and I went in to see her and actually the specialist nurse. And she went through all the questions, and she said, right, you're of a certain age. Won't quite reveal what age, but a certain age. And so you're type 2. And what's your diet like? So I told her. She said, oh, that's interesting. But you never exercise. Yes, I exercise. And I wasn't particularly, by that stage I'd lost a lot of weight. And they sort of looked at me, and to give her her due, she said, they've got you as type 2, but you're a bit on the cusp. But they put me on metformin for a few months. The blood sugar wasn't coming down, and so they said, you've got to go and see the consultant. I went to see the consultant, and hence the conversation where he just looked at me and said, you're type 1. And then the journey started of being taught to inject, going through, initially one type of insulin, I'm now on 2 types of insulin, and just coming to terms with that. And coming to terms with it, of course, in a job that was very, very stressful, a job that had significant highs and lows. One of the things I later discovered when I became Prime Minister was that my blood sugar always went up just before Prime Minister's questions. So I had to adjust according to that. But these are the decisions and the thought processes that anybody with diabetes is having to go through throughout the day, to recognise that constant challenge of balancing your blood sugar and keeping it within, as best you can, keeping it within range. So, but of course things have changed significantly. And I remember actually an event that I went to. I became involved with what was JDRF, now Breakthrough T1D. I'm an ambassador for Breakthrough T1D, the charity that works fundamentally to raise money for research for diabetes. And I remember being at an event they were holding in London. And there was some mad man who was just chasing me around this event. And he finally caught up with me, and he said, I want to tell you about this thing. It's called a freestyle libre. It's wonderful. It will change your life. And I thought, don't know anything about that. But of course, I then came to find out more about the freestyle libre, because that's the sensor that I use. As it happened, Abbott, who produce it, were a company based in my constituency, I then discovered. So I had a link with them. And of course, I went on to Freestyle Libre, and then myself tried to campaign, talk to the Health Secretary, and of course, the charities were in the UK were constantly pressing the government to enable the CGMs to be fully available, a full range to be available on the NHS, which they now are. As it happens, I saw that man who was chasing me through that event at Lord's at an international test cricket match in the summer. And he said to me, right, he said, I've got it for type 1s, now my campaign is for type 2s on the NHS. So he is carrying on with that campaign. The technology has changed the way that we deal with our diabetes significantly. And anybody who asks me about it, I remember, and we have a number of members of the Scottish Parliament here, and indeed a Scottish member of the Westminster Parliament. They will understand me, and Sir Michael will understand when I say I was a little bit surprised when I was still in the House of Commons when a member of the Scottish National Party came over to me and said he wanted a long chat with me. But it turned out his daughter had type 1, and she had been recommended to have, as it happens, the Freestyle Libre, and she was uncertain about it. And he said to me, should she have it? And I said, yes, it will change her life. And he came up to me about 6 months later and says it has. She took it and it has. So it is becoming much easier for us as diabetics to deal and to manage our diabetes. And when I meet people, as I do, who have had diabetes for many, many years, some people, I remember a gentleman I met at a charity event who'd been living with diabetes for 60 years. And he was going through the change that he'd seen over that time. I think I'm fortunate to have contracted it at a time when the technology is so advanced. I think I'm also fortunate to have contracted it later in life, because I think for children it can be incredibly difficult. And I remember the mother of one who is somebody who raises funds for Breakthrough through T1D, whose small daughter was diagnosed at about the age of 2. And this mother said one of the difficulties in the early days was us having to inject this small child constantly, finger pricking and at that stage, and injecting. And it's really difficult when you've got your small child there, and you know it's going to be painful for them, but you're having to do this. And then as young people, and there may be some people here who were diagnosed at an early stage and have lived through teenage years with it, but in the teenage years I think it's particularly difficult if you feel you're not able quite to do everything else that the peers around you, that everybody around you is doing. So I consider myself to be fortunate. I have, as I say, I use the Libra. I'm not a great adopter of technology, I have to admit. So I'm not, I think Anna said yesterday that she is, and she's got the pump and she's got that. So I don't have a pump, I still inject, but now I do it more openly. In the early days, I would always go, go out to the restroom and do my injection. Now, I'm much happier at just doing it at the table when I'm at a dinner or something. And I think that's important, that people understand what you're doing. Now, in the early days of my diagnosis, very few people knew, and I didn't make it public. And then there came a point where I just thought, actually, you know what? I probably ought to tell people about this. And in fact, it was a sort of, the thinking behind it was a little bit of this, that as I say, I used to go off and inject before I was speaking at a dinner or something like that. And I just thought, what if somebody catches the Home Secretary injecting themselves? They might wonder what I'm doing. So it's probably best if they know the truth rather than start rumours in the press about what I might be doing. And so I put it in the, did a newspaper article. Actually, I was interviewed by somebody who now works, then went on to work for me at the Home Office in number 10, and now still does some work for me. She's in the House of Lords. And I also remember, as it happens, I was on holiday when this was coming out in a Sunday paper. And I rang number 10 and said I wanted to speak to the Prime Minister, David Cameron. And his Chief of Staff, Ed Llewellyn, spoke to me and said, well, you can tell me, what is it? What is it? I said, no, I need to speak to the Prime Minister. And I had this vision of what they were thinking in number 10 Downing Street. What has she done? What problem is this? Why is she resigning? You can imagine the thought processes. So when I said to David, just to let you know, there's an article in the paper tomorrow about me having been diagnosed as a type 1 diabetic, you could hear this sigh of relief at the other end of the phone. Only that's all right. But visibility, I think, is important. And I commented yesterday afternoon that when I'd been identified as type 1, a number of other parliamentarians came up to me and said that they were actually diabetic too, but hadn't been talking about it. So I think that visibility, that talking about it, is important. And the other thing that I would comment on is the visibility of the technology. And in fact, Anna was having a conversation with me about this last night, but I can also tell another conversation. As it happens, I went to see, I was having my flu injection at our doctor's practice back at the beginning of October, and not the GP I normally see, but another GP was doing the injection. And she said to me, I just want to say thank you for wearing a sleeveless evening dress when you greeted Donald Trump for his first visit and being photographed with the Freestyle Libre on your arm. And she said, after that, we had a flurry of women with diabetes who came into the practice and asked if they could have the technology, because they had been worried about wearing this thing, what it would look like, what people would think about them. They saw a prime minister doing it, and they thought, actually, no, it's okay. And so don't be afraid, none of us should be afraid, to be visible about our diabetes, and to, because we are encouraging others. And I get quite a few letters in, particularly from parents of young children, saying what advice can I give them and what message can I give them. And I always give them the message that, for those of you who were there yesterday, I quoted, which is the Steve Redgrave message. Diabetes has to learn to live with me rather than me living with diabetes. And I think that is hugely important. But as we heard also yesterday, and as I heard in conversations last night, this is easier said than done in some countries. I'm fortunate in being in the UK. We've still got a way to go in making sure that everybody does have full access to all the technology that's available. There's a lot of work being done, a lot of research being done, but it's not like some countries, as we've heard, like the problems in somewhere like Pakistan or in low and middle income countries. And somebody was telling me last night about the definite stigma that they see in the workplace and jobs that are just not available in where they are for people who want to go into certain careers for people who are diabetic. So there is an enormous amount that we still need to do. So it's a pleasure to join you and be able to share one or two of the sort of things that I have been through on my journey through diabetes and continue into the future. And I think the thing I must always remember is you can get it late in life. Don't think it's just something for children. Be aware, be teaching others, be visible, be an example and a role model. I think that is what is important to us all. And can I, Mr. Speaker, thank you for your words, because you have continued the thread that was started yesterday, and I'm sure will continue through this conference, that this is not just about people coming together and talking. It's about people going away and acting, and that's a message for us all.
Thank you very much, Baroness May, for your excellent address. I'm sure that there will be some questions from the floor. So I invite members from the floor, first of all, to identify yourself when you want to make some comment or question. I invite Honorable Claudette Buttigieg. I don't need to have you to introduce yourself. I'm introducing Honorable Claudette Buttigieg from Maltese Parliament.
Thank you, Mr. Speaker. It's such a pleasure to be here this morning. But I wanted to immediately say a huge thank you to Baroness May. I remember very clear that beautiful dress, sleeveless and with your technology stuck here. And I still remember my daughter telling me, oh, look, Mom, she's got one. When are we getting ours? And then eventually, I'm very grateful also because in Malta, our children are wearing technology. Of course, there's still a lot to do, and yesterday we had a lot of discussions about this, and I'm very hopeful that we will get there, but there's still a long way to go. I just wanted to say, from a personal point of view, how appreciative we all are to your example. It is so important to have somebody so iconic like you doing what you did, so thank you.
Thank you very much, Honorable Claudette Buttigieg. Introduce yourself.
Thank you. It's an honor to be here today. Thank you, Mr. Speaker. I just want to say thank you, Baroness May. You are an image, an idol for so many people who knew I'm coming here from Lebanon And my daughter said, please tell her thank you for being who she is for all of us living with diabetes. And you setting this example means a lot. But my comment here is CGMs are very important, but please let us always remember the word access. It's not accessible, nor available, nor affordable to many children or adults living with diabetes in the low middle income countries. And this is a call upon all the parliamentarians, all the policymakers to please look into that. It's not fair nor just, and it's against human rights for some people from our population to have those fancy and nice and health setting, I could say, devices, whereas the large, vast population doesn't. So this is a call to action for all of us when we go back home to be persistent, to be perseverant, and to knock on doors day and night in order to get the right policies and to give that access, which is a human right, not a privilege, to those people. Thank you so much.
Can you kindly identify yourself? For the...
Yes, I'm Dr. Jackie Malouf. I'm from Lebanon, but I am currently here on behalf of Professor Schwartz as Vice President of the International Diabetes Federation.
Thank you very much. Shukran. I call you now, please.
Thank you. My name is Sarah Ball. I'm a Member of Parliament in the United Kingdom. I've met Baroness May a few times before, but I want to say just again the thank you about the visibility is so important. When I was first diagnosed only 4 years ago, I had no idea about type 1 at all. I started losing weight and thought I'd found the secret to a dieting, but it turns out it definitely wasn't. But I contacted Baroness May's office and they basically arranged a 20-minute call. And you explained all about how you handled it during the Brexit years, and it honestly really gave me the inspiration to be able to continue. And as my friend said, though, only you would contact a former British Prime Minister, Sarah, to ask for advice. But I would always just say thank you so much, and it really means an awful lot to us all. So thank you.
Thank you. Do we have any? Yeah.
Hello, my name is Sana Ajmal. I'm from Pakistan. I'm a person living with type 1 diabetes and currently the Secretary General of PDGN. Thank you, Baroness May, for sharing your story. You're a huge inspiration to people everywhere. It's not just about these countries that speak English. It's not just about the high-income countries. It's not only about children or young people who are able to wear the CGM. It's also for everyone, for people who cannot even afford insulin. I wanted to echo what Jackie Malouf pointed out. And I want to request this forum to please make technology accessible for everyone, everywhere. It is a life changer. Can we do that? Can we think about joining hands together to save lives and to improve them? We don't want more people. For example, Pakistan is a country of 230 million people. We don't want more people living. We want people to live well. And they can't live well with just insulin and test strips. And sometimes not even insulin. So that was my comment. Thank you so much for sharing your story.
Thank you very much.
Good morning. I'm Mark Baron from Forum CCNTs, Brazil. Thank you so much for the opportunity to be here. And thank you and congratulations for all your work, Baroness May. If I could so align with what Sana just said and Jackie said as well, I would appreciate if you had a recommendation for parliamentarians all over the world for developing policies that would give access to people living with diabetes in different countries. We know that UK is very much advanced in access to technologies and to insulin, etc. But we know that in some countries, people don't have access to insulin, don't have access to strips, so to basic things. But we know that the UK has passed through phases, through steps, in order to have the incorporation of different technologies and different medicines. So what would be your recommendation to consider, so from the beginning, those incorporations that would allow people living with diabetes to be healthy and to have, to prevent their lives to be shortened without access to insulin and other technologies that are necessary? Thank you.
Thank you very much.
Thank
I have
you.
another comment.
I
Yeah. No, Terry.
referenced a number of ways in which I thought I was lucky. I also think I'm lucky to live in the UK because, by and large, there is still quite a bit for the NHS to do to make sure that everybody across the UK with diabetes has access to their regular checkups and so forth. But by and large, we are ahead of a number of countries. And as has been referenced, of course, it's access to technology, but even access to insulin is difficult in some places, including in a country like the United States, where I think you still have to pay for your insulin. So, I mean, in the NHS, it is free on our prescription and NHS system. So, what is the recommendation? Well, the difficulty is, first of all, making sure that governments understand this is an important issue. I said yesterday that I think one of the arguments that sometimes can help governments understand that is actually the argument about cost. Because if they don't provide these things, if the people are not able to access what they need to prevent complications, to manage their diabetes well and prevent complications, that will then be a cost. Now, of course, systems change. Systems are different in different countries in terms of healthcare and so forth, and access to public healthcare. And so this argument is of a slightly different order in different countries. And unfortunately, dare I say it, there may be some governments where the fact that there are some of their population who will die with diabetes is just not something that hits their headlines and gives them the level of concern that it should. And I think we talked a lot yesterday about awareness raising. I think there is a real issue about just letting governments understand that this is something that is not inevitable for somebody to die or have complications with diabetes. It is possible for people to manage it in a way that they can live fulfilling lives, lives which contribute to the country, lives which contribute to the economy of that country, and lives which contribute their talent to that country. But there are some governments around the world where I think the first stage is just getting that message over, let alone then encouraging them to give access to the insulin, the technology, and so forth.
Thank you very much. I can take another one from there. Yes.
Thank you, and can I join everybody else and thank you for leading the way for those of us who were the patches and helped to overcome stigma. And the sight of you in Prime Minister's questions, swiping your arm as you had to then before they were continuous, was a great symbol to other people that it was okay. I wonder if you might say a little bit more about the barriers to technologists. I should have said Chris Renard, UK House of Lords, where I also sit with Baroness May. And I raise regularly these issues, but there are barriers in persuading governments to invest in the technology. And I think the problem is that whoever is in charge, the Treasury, the Finance Ministry, they want control over the purse strings, and they don't like investing in the technology if the savings from it don't come back within a very few years. And being suspicious, I always think this is because the party in power wants the savings while it's in power, but doesn't worry about the savings that another government after the next election might benefit from. And what we should really be doing is looking 10, 20 years ahead for the savings that would be from diagnosing more people, investing more in the rollout of the technology, and helping people maintain their control much better, as I have painfully learned to do in my own story. But is this the problem, that the ministries of finance just want to have savings rapidly and not long-term enough?
Okay. Thank you.
I don't think it's necessarily that. I think there's I mean, if you take the NHS as an example, the UK as an example, I think it's not just about the finance ministries. Actually, it's just persuading healthcare ministries that this is an important issue for them and that this is not something. I think by and large, if you look at healthcare systems around the world, they tend to deal with the emergency, with the sudden thing that comes up, with the acute. And the chronic conditions is something that have all too often in the past not been given the attention they deserve. And I think that that's changing in many places, but I think there is still a mindset often even with the healthcare professionals, that this is not something, unless they're really, the diabetes specialists, that this is something that we should be doing. So I think there's an argument before you even get to the question of the finance ministries. But as I say, I think there is a cost-benefit argument that can be put. But the savings, the savings can actually be quite quick. This is not, if somebody moves from having to continually finger prick to being able to use the technology and as a result immediately or within a very short space of time manage their diabetes better, their performance in the workplace will improve, their ability in a whole variety of ways will improve, and so there is an immediate benefit. Sometimes, though, it's quantifying the benefit that is the difficulty. It's not when the benefit comes, it's how you quantify it in a way that makes sense to those finance ministries.
Thank you. We have to move because we're a little bit time behind schedule. We now go for Professor Peter Schwartz to make his presentation.
Thank you, Mr. Speaker.
You have to stand up, please.
Oh. Thank you, Mr. Speaker, and for everyone here, I have to apologize for Professor Schwartz as he is ill at the hotel. He's here in Malta, but unfortunately, he's not feeling well. As Vice President of the International Diabetes Federation, I've been asked to deliver this presentation. So, okay. Oops. I have to work on two things because I can't see enough from there. So, for those of you who are not very familiar with the International Diabetes Federation, it is a global voice for every person living with diabetes across the globe, with 256 national diabetes associations, and honestly, I preside one of them from Lebanon, a very small organization, and we are members, so this is the umbrella for so many others, and it's present in 158 countries. Also, we have 590 almost million people living with diabetes. Mr. Speaker mentioned that earlier, referring to the International Diabetes Federation as a source. I would like, this is not changing, is it? Can someone help maybe in changing that? So the vision is to give affordable access and quality of diabetes care and education worldwide, and the mission is to improve the lives of people living with diabetes, because we don't want to add years to the lives of people living with diabetes. We want to add life to those years. We have 4 impact pillars. One is awareness. We spoke a lot about it, and Baroness May just mentioned it. Also, very important pillar, advocacy. And I take pride in saying I'm a global diabetes advocate as a mother of a lady living with diabetes. We have a 3rd pillar, epidemiology and research, and we work a lot on that. We have many publications on the name of the International Diabetes Federation, and our global programs, if I may mention just the 2 related to young people, mainly the young leaders in diabetes, and the Blue Circle Voices, not only young people, everybody living or affected by diabetes. And so just very, very quick numbers, that 1 in 10 adults are living with diabetes, but 80% of those are in low middle income countries. We were talking about the access and education and lack of availability sometimes, or affordability. 80% of that happens in low and middle income countries. Now, the main point of the presentation today is to launch a new project called the GDI, or the Global Diabetes Index. There was a large debate about whether this should happen or not. Should we measure how a country is acting in regards of diabetes? Would that be taken well or not? But definitely there is a lack of data and measurement tools or metrics about countries, and we believe at the International Diabetes Federation that this is very much needed and it is mandatory to have. But please consider, as I go on to with the presentation, that this is a pilot year for our project. So it's in the early stages of the launching, so many things may be changing further ahead, but not the basics, as in purpose and roles, to create a universal metric, as I mentioned, to measure and compare, kind of a benchmark, not with the purpose to blame, but with the purpose of showcasing what is happening on the ground, and maybe create this healthy competitiveness between countries to, measure higher and higher every year, and with the ultimate purpose of benefiting, of course, the people living with diabetes. It is happening currently over 87,000 participants, people living with diabetes, in 100+ countries. It provides actionable insights to inform policy reforms. As you mentioned, they need to know what's happening before proceeding with policy changes. So this would be a great tool for government to proceed and adjust or maybe create, if they're not existing, good policies. What is the rationale behind the Global Diabetes Contact Index? It's first of all the need for universal metrics. And of course, this is done by a huge number of professionals, not only in diabetes, in technology, in AI. It needs a lot of work to compile what has been done, and again, it's still in process. And the idea is to launch it every year, 3 weeks before World Diabetes Day, with updates. So every country, if they're not happy with their result, they have 9 weeks, 9 a month, 1 week to work on that and to make those metrics change at a yearly rate. And the disparities in care are a major rationale on why the need for a global diabetes index. We were just talking about the different approach in different countries in relation to diabetes. And as we speak even about CGMs and technology, how can we ask people living with diabetes in, let's say, displaced communities, if they don't have a smartphone, how can we ask them to cope with technology? So there is a lot of disparities, and there is a lack of evidence for policymakers. So the purpose is to provide a good piece of evidence with metrics, with numbers, for policymakers to base their decisions on and to update their policies if needed. Of course, as nothing else comes with just easy, there are many challenges. First, there are data gaps in many of the countries. The presentation is long, so that's why I'm not going through a lot of details. The second challenge would be the care disparities mentioned earlier. The third challenge would be the policy inertia in some cases. I apologize, this is not addressing anybody in particular. This is data. We have to say things as they are in order for us to know the reality of what's going on. And how does the Global Diabetes Index work? It is a global survey. It will be translated in 50+ languages, so everyone can understand the details of it and the rationale and the outcomes and everything. Now, amongst the people surveyed that I mentioned earlier, the 87,000, we have 50% of those are people living with diabetes. We have 30% who are healthcare providers and 20% policymakers. And this is very interesting because I don't believe a study like this has ever happened before, combining all the stakeholders, basically. So again, it's across 100 countries, and it has an AI-powered analysis. That's why we have on board specialists in technology, in AI, and we know now AI can do wonders, but it has to be managed from our point of view by humans we need to feed AI in order to get what we need from AI. And it will serve as an advocacy catalyst and release results, as I mentioned, 3 weeks before World Diabetes Day every year. What are the objectives? First, to have an annual multinational survey to be launched on World Diabetes Day or 3 weeks earlier. Second, to have an AI-powered data platform. Third is the dissemination for advocacy and with the purpose of helping people living with diabetes, healthcare providers, and governments to mandate their policies. Number 4 would be the monitoring progress, as it is an annual release. It has an annual release. The monitoring will be really important in order to change those numbers, hoping to have those numbers and those indexes increase in awareness and in access every year. And another objective would be fostering partnerships, which definitely I believe we all believe in partnership, and it is in the goal number 17 of the Sustainable Development Goals by the United Nations. What is the intention of the survey? First, it is to describe the current situation of diabetes care in every country. It is to identify what we are lacking and what we have on the other hand, so the deficit in cares. It is to inform policymakers. It is also to set international country ranking, again, not with the purpose of blame, but to create a healthy competition, let's say, in order to better serve the people living with diabetes, show temporal developments happening every year, and to improve the diabetes care, which is definitely our ultimate goal, to improve the care of diabetes. And the objectives of this survey is to gather stakeholders' insights from all the specialties across the diabetes spectrum, to using standardized global tools, and to give annual reporting and policy impact. Who is invited to participate? 19 diabetes-relevant groups are invited to participate, and I'm talking worldwide. This is a global survey. We have people living with diabetes. As we always say, they must be at the center of the decision-making throughout the process, not only at the time of the decision-making. They need to be, from the beginning, sitting at the table, sharing their views and perspectives. Also invited are care providers like doctors, nurses, and specialists in diabetes, and other stakeholders or groups with diabetes-related careers can also participate in this. The standardized questionnaires will allow us to know about the situation of access to diabetes, public health and intervention, early detection and therapies, and this will be a cost saving, as Baroness May mentioned earlier. The care process and management to see the gaps, the disparities, and to correct them, and to serve as research, education, and self-management tool. I will speak very briefly about the EU because this is one of the first outcomes of the Global Diabetes Index. The interesting thing here is that the questions were directed to people living with diabetes, to healthcare providers, and to other stakeholders. And again, I believe this is the first time a survey of this magnitude involving so many countries is comparing the perspective of the answers to the same exact questions from healthcare providers, people living with diabetes, and other stakeholders involved around diabetes. So I will not detail because there are, again, many slides. So what we can see here is interesting that in some countries, the answers between people living with diabetes and healthcare are very similar, whereas, and we're not disclosing the countries at this point, whereas in different countries, you see a big disparity. For this example here, 57% of people responded in one way people living with diabetes, whereas 87% of the people responded that they approve that particular question. So you can see there is a big difference. The idea is to understand why those differences and to, bridge those gaps. So here you can see how the index is going to be displaying. The countries have numbers at this point. So this is, again, EU member states in Europe. What you see as a total score is a percentage. So it goes, I hope nobody will have that score, 0%, it goes to 100%. And the beauty of this is that maybe one country that scores 60% this year and they're not happy about their results can really work on that and maybe have a 65 or a 70 the next year and then progressively hoping to get to the 100%. But you would be surprised that some countries that we consider the developed countries are not scoring as good as we expected, whereas some small but underdeveloped countries are scoring better than we had expected. So this will serve as an excellent tool of benchmarking to help us make things better. I will skip some of the slides as they have a lot of information, but will stop at this one about the quality of care across all EU countries. You can see here the countries and the percentages, and this again will serve as a very, very rich and in-depth data to be analyzed so we can offer a great tool for the government of those countries, discuss with them how they can improve if that is possible, for them to work internally to improve what they don't like in the results. So the comparison with USA and India is something because of the differences in numbers. Again, will not go a lot through this because more data is coming in. This is a soft launching of a pilot project, and I would like to really emphasize on that. But the project is going very well, and we are counting on collecting more partners so we can proceed at an even larger and bigger scale. The main findings is that about standardized and annual surveys, where the global survey that is conducted using a standardized questionnaire has the purpose to ensure consistent data across all the participating countries worldwide. So it's not like there is a specific questionnaire for Europe because they have better policies. The same questionnaire is standardized for all countries whatsoever. And it's very inclusive of stakeholder participations because we are collecting perspectives from all stakeholders across the spectrum of diabetes. And it is a comprehensive coverage where survey questions address all the critical levels of diabetes. Bear with me because I know data information can be boring. Thank you for your patience. Okay, so what is the use of the Global Diabetes Index data? Some things also can be repetitive, but you understand that in every report we need to repeat the important information, is to present what is the current situation, to compare countries as a tool of benchmarking, to identify weak areas and gaps and to try and bridge those gaps, to guide treatments, improvements, to motivate policy reform based on data, not just asking for policies, but presenting data in order to get better policies and to develop international ranking. I know from the feedback we've gotten so far, some countries are very excited about this Global Diabetes Index. Others don't because they're afraid of the numbers that might come in. But I have a call here to every single country in the world, every single government. Again, this is not with the purpose to blame. This is to really know where we are standing in terms of diabetes care, diabetes education, everything related to diabetes and how we treat the people living with diabetes, and to make it better for everyone. So how to join the survey and the steps, you have to visit the globaldiabetessurvey.com, click the register yourself, fill all the information, submit your registration to receive survey invitation. It might seem complicated, but it's only a few clicks. So I invite you to massively participate in this survey. The actions and the timeline is very important, where we see the first year, as I said, it's a pilot and to set up the platform. From 2026 to 2027, we consider it year 2, is to scale up and to broaden the engagement on the survey. And then 2027 to 2028 is the sustainability and impact, where we start looking at improving what we have, but already it's broad enough, engagement is big enough. Okay, so the expected impact by 2028 and 2030 is over 40 countries will implement the Global Diabetes Compact informed reform. This is something amazing if it happens. We're optimistic and we hope this will happen. And the research and benchmarking by 2020-30, where more than 50 research studies will utilize the Global Diabetes Index as a reference. This is really what we are hoping, to create a reference.
Can you kindly conclude, please?
And a tool. Okay, so the purpose of this Global Diabetes Index is to transform the diabetes care across the world, and I was going to go through some of other projects, but the time will not allow. Thank you very much.
Thank you very much for your extraordinarily important information on the Global Index of Diabetes. Now I invite members from the floor to make a comment or ask a question. You've got the floor.
Thank you, Honorable Speaker. I would like to pose a question.
Can you state your name?
All right. I am Consilia Chinanjawana, Member of Parliament, Zimbabwe Parliament. Thank you. My question would be that, considering the statistics, if I heard it right, that 80% of new cases or those that do not know as yet are in the Global South, then how is it really defining the Global Diabetic Index, considering that there is lack of evidence for policymakers without reliable, comparable data, where there is no awareness at all in the Global South? Some of us don't even know that we have it, level 1, level 2, or anything at all. We can't even afford diagnosis. How then can we make the call to action real? I thank you.
Thank you for your question. I understand the Global Diabetes Index points, yes, the 80% of people living with diabetes being in the Global South or in the low-middle income countries. What we try to do here is, by pointing out numbers based on current and available data from each country, we believe that we are motivating governments to do better in surveys, local data, local registries, in order to every year progress. Somewhere we have to start, my dear MP. I know and I hear you, and I know the situation is way worse than we think in some of the places. But again, there is a starting point, and we believe at the International Diabetes Federation that by starting this Global Diabetes Index, this is exactly where we want to go. We want to motivate your government, my government, and every other government to look at the lack of data, to look at the lack of diabetes care in their own countries, and start improving little by little. I believe nothing is going to happen overnight. There is no one-size-fits-all. For every country, for every government, things are going to be different, but at least we are trying to create a measure, a metric, where Zimbabwe or Lebanon or South Africa. We can look at where we are standing. If we don't like it, we need to improve it so we are standing in a better position. I hope I responded to your question, and thank you.
Any other question or comment?
Thank you very much for sharing about the index. My name is Lindsay McCauley. I'm Director of Patient Engagement at Diabetes Action Canada and a person living with diabetes. I respect the point about data disparities being a reality. I'm curious about even where we have data though, are there any guidelines on, because this is a self-reported survey, on what robustness of data looks like when we self-report? And the reason I ask is in Canada, while we are grouped with the higher income countries, people who are on insulin, less than 23% have CGM access, but that data set looks very different on Indigenous reserves versus not on reserves. So I'm curious, even if I was to submit for my organization, there's about 16 different data sets that all contradict each other. So are there guidelines from the survey on what robustness of data is considered at the global level?
Well, also thank you for your question. We have discussed that in depth, and yes, there will be guidelines set by professionals, which I cannot talk about now because I'm not in charge of that. But again, this is a call to look at what we have and what we are lacking. But somewhere where we are starting, we need to see what we have now, and when those disparities start looking so evidently in front of our eyes, then we can communicate with that particular government or with that. I mean, look at the Diabetes Atlas. I personally have reported to IDF repeatedly that the numbers reflecting what is happening in some of the countries, because I've received emails, are not reflective of the reality of the country. But how can we do more? We're trying to do as global as possible. Here is a call to be authentic when you fill out the surveys. Please give us the true data. Don't give opinions. I mean, there is a part where you have to state your opinion. But when it comes to data, we need to really reflect the truth. And that's the only way to change that reality, because no matter how many guidelines we set, if we are not true to the data we are giving, nothing will happen. This is always going to be one of the major challenges, many data around us. This is a call to unify the data in every country. Again, we have the same problem in Lebanon. I've been always calling to unify, to make a unified diabetes registry. Then we can base ourselves on facts and not on opinions. So it's a challenge. I understand what you're saying. We are considering it in the Global Diabetes Index. It may have a lot of gaps in the first year. We will be correcting it as we progress with your help. We need your help to make it better every year. Thank you.
Thank you. We move to the next presentation. I call now Professor Godingaria to make your own presentation on the WHO Global Diabetics Compact and conclusions.
Thank you.
Speaker Anġlu Farrugia, Baroness Theresa May of Maidenhead, Sir Michael Hurst, Krista Licata, Honourable Members of Parliament, Vice President Jackie Malouf, and through you, President Peter Schwartz, colleagues, friends, ladies and gentlemen. There should be slides up there, and there should be a clicker in my hand. So could you... Ladies and gentlemen, 3 words: justice, science, passion. We have oodles of them in this room, and if you take only 3 words from what I am going to say, let them be these 3. Justice, our common call for equity, for access to medicines and technologies, for lessening the disparities between countries by size and income. Science, everything we do must be evidence-based. Our common challenge to collect valid data, to quantify the burden of diabetes, to show how effective solutions can reach good return on investment in a short period. And passion. In a world where multilateralism is declining, where bigotry and stigma are being justified, even often glorified, we need to find the passion to move from simple advocacy, simple reports on what the data is saying, but into activism. What form that might take will be a new evolution for diabetes in the coming 5 years. But hear me, this evolution is needed. I'm going to speak about the Global Diabetes Compact. As you may have noticed, I'll be technical, but I want to also be political. We are, of course, a network of parliamentarians. I am not the only presenter, although the one speaking. I pay homage to the other people in WHO. I have now recently retired, and I'm representing WHO as I speak. So Bianca, Alarcos, Guy, and Jill, it is their work that I am also reporting upon. We have the Global Diabetes Compact. Unique among the non-communicable diseases, we have a resolution unanimously adopted by WHO, the World Health Assembly, to reduce the risk of diabetes, to ensure that all people who are diagnosed with diabetes have access to equitable, comprehensive, affordable, and quality treatment and care. It gives us an agenda for every parliament. And it is heartening to see, with the leadership of Baroness May, but with the smaller and maybe less visible leadership of so many parliamentarians who themselves have the experience of diabetes, that the voice for these values can be made. And these values are only empty words unless they can be enacted in legislation, in regulation, within the countries, the member states of the world. I remind everyone that yesterday was the World Diabetes Day. We celebrated it, and in WHO, the theme was diabetes across life stages, highlighting the importance that a life course approach is necessary for us to act early, to reduce harm, to support people through each stage of life. And diabetes is really a disease that affects everyone from womb to tomb. Gestational diabetes deserves a mention in this forum. A mother with diabetes in pregnancy has a marker for her own future, type 2 diabetes, as well a marker for the child's eventual cardiovascular risk and metabolic risks. We've heard about type 1 in children, the social, medical, and economic issues that arise, and not least, maybe most prominently, the emotional ones. For legislators, a life course approach to diabetes means more than just legislating for specific technologies. It means looking at the determinants of health across all the sectors. And this is very important, that it's agriculture that needs to come in, trade needs to come in, industry needs to come in, education needs to come in. So diabetes is not just a problem of one single sector, but it is a problem of all sectors. Since 1990, you can see the size if you can't see the numbers. Since 1990, diabetes has quadrupled in size, in the amount of people with diabetes. And we are now at or above 800 million. 59%, current estimates point to hundreds of millions of people living with diabetes, with numbers still climbing. There's a steady demand for longer-term care, for regular monitoring, for protection against complications. There's a huge amount of lack of access to medicines and technologies, and 90% of that is in low and middle income countries. This has already been highlighted in the reaction to Jackie's presentation. So it's a problem that's rapidly rising, causing great burden on people's lives and on economies, and it is hardest hit in the most vulnerable countries around the world. The World Health Assembly Resolution 74.4 is established the Global Diabetes Compact. It called on us all to strengthen and monitor national diabetes responses. We need to hold politicians, parliamentarians, ministries of health, governments accountable for their response and their programs on their response to diabetes. We need to develop clear pathways for achieving the 5 targets that I shall soon talk about. It's very important to legislate for access to essential medicines, to diagnostics, to screening and care. It's important to adopt policies across all relevant sectors, agriculture, urban planning, I've mentioned so many. Diabetes risk is shaped outside the clinic. It is shaped in the environment, in the food system, for example, and it is very important that we are aware of it across as a pervasive influence. We must, and this is a new keyword that I'm bringing into this discussion, we must look at diabetes in the context of humanitarian crises and emergencies. I like to say that the people who are most vulnerable to earthquakes, to extreme temperature events, to conflict, are the people with chronic disease. They are the ones who will lose their supply chains most quickly. They are the ones who will lose the continuity of care. They are the ones, once water safety and food security has been established, they are the ones who will die first because of the lack of treatment. We must increase transparency in markets. Companies too frequently negotiate, divide, keep agreements blind, opaque from one country to another. This creates distortions of the market. So you must not simply adore the market and see it as a solution to everything. We must find our ways of increasing transparency and harmonization. We must develop recommendations for sustainable financing. WHO and the World Bank organized a whole consultation on that in June of 2024. And the resolution requires us to submit annual reports to the World Health Assembly. So there's been a very rapid agreement, which is wonderful in this disrupted world, to reach unanimous agreement on anything. In 2022, April, the compact was drafted. A month later, the World Health Assembly, this was the 100th anniversary of the discovery of insulin. A month later, the World Health Assembly adopted the compact and made it a competence and a mandate for the whole of WHO and all the member states. Now, as we sit here, we are inspired by 5 global diabetes coverage targets. These targets, to be reached by 2030, give us a shared direction and a way to measure progress. They focus on early diagnosis, on good control of blood sugar and blood pressure, on access to essential medicines, and on regular follow-up to prevent complications. These are 5 simple targets that would be very complementary to the Global Diabetes Index, and one could find ways of collecting this information. I'll speak to that in a moment. These 5 targets give us a tool as parliamentarians to hold our own ministries to account, to ask for regular reporting on how well are we doing on the progress to 2030. I ask Elizabeth and Sabine to rise briefly. This is our joint project, WHO Europe together with IDF Europe, and you have, I recognize your presence here. So many others were present, but there were many months of preparation for a declaration that was co-signed by all the diabetes associations of Europe, is now available in all the languages of Europe. It's a declaration that takes the Global Compact into our region and defines our commitment. We have taken that declaration, and okay, I have retired. I still say we when it's WHO. Is just such a recent. I've been 27 years in WHO and less than 20 weeks outside. So forgive me for saying we. We have tried to look at the achievement of these targets in Europe, and here I asked Joao if he's, oh, you're chatting away, are you? Joao Raposo is one of the consultants who worked hard on this project together with Jill Farrington and so many others. We have tried to assess comparatively using the same methodology how diabetes services are delivered across Europe. It's very difficult to find common data. This is not new. We found that we had to use health examination surveys, electronic health records, insurance claims and benefit packages, and to triangulate this data where several sources existed. There are 13 volunteer countries who participated in this process. Not all countries enjoy being examined or assessed. And I will read out their names: Armenia, Belgium, Croatia, Finland, France, Georgia, Germany, Italy, Kyrgyzstan, Serbia, Spain, Tajikistan, and England in the United Kingdom. So there is a wide representation of West and East in Europe. There, I highlight 5 key results. So the percentage of our target percentage of people with diabetes who are diagnosed is 80%. The target is 80. The median in these 13 countries was 72%. We're on the way to achieving that in 2030. Glycemic control, that is well-controlled blood glucose, target again 80%. Our median in these countries is 82%. So in these countries, though there is wide variation, the central tendency is that we are there already and can strengthen our position. Blood pressure control, though, is the worry. Target is 80%. The reality is 63%. Why do I focus on this? I don't know why. I don't know whether I need to explain. But you can control the blood glucose until the cows come home. If you don't also control the blood pressure, all the complications will still happen. We all know the UK PDS. So the results show very clearly that we must do better in hypertension. Statin use is even worse. 60% of people aged 40 plus who have diabetes should be on statins. we found the average was less than 50%. I led a team over the past 2 years to develop to publish a paper called The Quick Buys in Non-Communicable Diseases, meaning those interventions in NCD that lead to population benefit within 5 years. Why did we choose 5 years? For 2 reasons. Because parliamentarians, ministers, typically are looking for impacts within a 5-year period. And secondly, because we have 5 years or less until we have to report on the Sustainable Development Goals in 2030. I led a team to develop a list of interventions called the Quick Buys. Statins is one of the most cost-effective, fastest ways of achieving population benefit. So we not only can we do better, but we must do better. A lot of lessons. There are huge gaps and inequalities. The justice keyword flashes here. Data systems are uneven, need a lot of triangulation. Much more can be done there. The targets need to be adapted to country contexts. We often assume that there is access to insulin, other medications, or technologies because it's so in the regulations or in the law. But we need to dig deeper and actually check whether the access has been verified. Data is great, but we need to translate it into action. And we can only do this if we engage the people with lived experience, the people with diabetes, meaningfully. We have 5 work streams, and given the green light, I will be very quick to go through them. The first one, a huge amount of work on access to medicines and technologies. This year, for example, essential medicine lists have been updated. The human insulin was pre-qualified in 2022. The new essential medicine lists include GLP-1 receptor agonists, rapid-acting insulin analogs, 10 ml vials of long-acting insulin analogs. They reflect current evidence, they expand the treatment options, and they create an agenda for action for all legislators worldwide. A whole range of technical products summarizes the science. Several ones are available. The PEN package about treatment of chronic disease, including diabetes, with HEARTS D being focused on diabetes in primary health care, a fundamental pillar. So there's a strong pipeline of new research in place. New clinical guidelines will cover insulin treatment for adults with type 1 diabetes, the management of type 1 diabetes in children, etc. Updated monitoring tools are coming, including a global status report, updated country profiles, red light. Prevention and health promotion is a third work stream. I highlight one project here, and that is the acceleration the accelerated action to stop obesity. Action has been summarized into 15 evidence-based interventions in 3 categories: change environments, taxing sugar-sweetened beverages, food product reformulation, food labeling, etc., awareness and behavioral change, transforming health systems so that they can respond systematically. A huge amount of work on country support. I highlight here 3 of 9 in-depth studies that have been done, and I commend you to the website to be able to see more. Research and innovation, we need to set the agenda for both health systems research, but also basic research these have been developed together with the Alliance for Health System and Policy Research. More can be said. And there's a whole set of fora where we bring the different stakeholders, civil society, private sector, research, academia, and of course, most centrally, people living with diabetes. I will conclude on the UN General Assembly 80. We've mentioned it yesterday, a major event, the 4th UN high-level meeting, great success. On one hand, 140 countries registered to speak, 90 ministers of health, 20 heads of state, hugely supported on the one hand. On the other, it's the first UN high-level meeting, and I've been in the background or foreground for all the 4 of them. First one that did not come out with a unanimous political declaration. We need to learn lessons from this, even though I put up a quote here that diabetes is well featured in the document. I think we also need, as an advocacy group, dare I say, as an activist group, we need to find new ways of working. We need to find new ways of connecting diabetes with trade, with security and human development.
Thank you very much.
Thank you, Mr. Speaker, and thank you for listening. Thank you.
Excellent. Now I invite anyone who we have 5 minutes to do any question or comment. Yes, you've got the floor.
Thank you, Honorable Galea, for the insightful presentation. You took more minutes than I did. We'll talk about that later. So my comment, maybe you have noticed, maybe not, but I would like to highlight that. At the International Diabetes Federation, we are talking about 589 million people with diabetes, whereas how many did you hear Honorable mention?
828.
No, it wasn't for you, the question. It was for that. Okay, so there is a discrepancy. The point of my intervention is to tell you, no, we are not wrong. Neither is WHO. The simple fact of the difference in criteria gives us this difference in outcome. And I found it very important to mention it to you. My own organization is a member at the Global Diabetes Compact. I would like to commend the work that is happening. And related to the UN high-level meeting, we talked about it yesterday as well. I was there as well. I feel that diabetes was not enough represented. It was at the beginning, maybe, at the zero draft, but then it got diluted. Yes, we are here to learn our lessons. Thank you for reminding us of that. And we need to work on that next time to break the gap between what we want and what our government know, so our government can really display the right messages in order to avoid what happened this year. But I believe there was political implication
Can you conclude
to that. Thank you.
Okay. We take another question. And yeah.
Thank you very much. Professor Galea, it was great to see your presentation. Some of us have been collaborating with the teams of Dr. Bianca and Dr. Guy here for the several efforts for diabetes and NCDs in general. And I bring a concern related to what you presented, the political declaration, where diabetes appears as a paragraph for strengthening diabetes in primary health care, but the Global Diabetes Compact is not mentioned. So for this reason, we, people living with diabetes from different countries, we wrote a letter to several countries asking to ask for this change to include the Global Diabetes Compact targets into the political declaration. This letter was signed by 245 people and 74 different organizations. But unfortunately, this didn't happen. So the Global Diabetes Compact targets were not included in this important political declaration. So I would appreciate if you could comment, what are the risks if countries now that are committed with this declaration don't see the clear targets reflected in this new declaration that was just agreed?
Okay, you can answer the question, Professor.
A quick answer to both, because you both raised very rightly the UN high-level meeting, although only one of you mentioned the minutes of overrun. We'll talk about it later. I'll take the liberty of taking off my WHO hat and putting on my University of Malta hat and talking a bit like an academic rather than... I observe, and I've been in the political process of UN high-level meetings since 2011, including having been in the team that justified the first meeting and worked with ECOSOC and other UN bodies in order to have the first meeting, that we have gone from a united approach on non-communicable disease into where can I get my paragraphs. So the kidney people want their paragraph. The neurological disorders want their paragraph. The dementia people want their paragraph. The mental health people want their whole separate declaration. I am afraid that we are fighting technical battles on the floor of the General Assembly, which technical battles should really be reserved for the World Health Assembly. And we should find the unifying voices on trade, on security, on climate change, where NCD and these overall drivers unite us rather than divide us. So if we want our targets, we get them in Geneva. But if we want the commitment of foreign policy and trade, then we fight for it in the General Assembly. My 2 bits.
Thank you very much.
Thank you.
We move now to the next presentation by Honorable Sonia Situ from Canada about the Diabetics National Plan in Canada. You've got the floor.
Thank you, Mr. Speaker. Distinguished guests, Honorable Member of Parliament, health leaders, and esteemed guests. Before I start, I really want to say thank you, PDGN. Congratulations, Michael Hurst and Sana. When I was in Portugal, that time we have less members, and congratulations to when I'm seeing this very successful PDGN meetings. And yesterday on Diabetes Day, we have a successful panel. And thank you, Mr. Speaker, and Chris, hosting us in your parliament. Thank you so much. And it is a tremendous honor to join you here today at the Global Parliament Forum in Malta. And one thing I just want to, I'm listening many speakers, we all know that the diabetes burden, if I talk about Canada, is $13 billion in healthcare burden in 1 year. So we all know that. And thank you, all the speakers who is working hard. And then I was talking to Ukrainian parliamentarian who came all the way over after, because we have a passion. We want to do something in our countries. And these PDGN and many other global form as very, very essential. And many activists here, I want to recognize Lindsay, who came with me from Canada. She's working hard on the ground. And many others, like we have transfer our views. And beside, Dr. Jackie, yesterday, Madam Theresa May, and powerful discussion yesterday we had. So we need to move a needle. I know Baroness May move a big needle in Europe, and this is something we are inspiring each other today, and that inspiration we are taking to our country, then we can transfer diabetes care and advocacy. As a proud Canadian, I cannot begin without reflecting on a moment in history that forever changed global health. More than 100 years ago, a Canadian scientist, Dr. Frederick Banting, and his team made a discovery that would save lives of many who are fighting with the diabetes. In a small laboratory in Toronto, Banting and his team discovered insulin, giving hope to people who until then faced a terminal diagnosis. It is a discovery that not only transformed medicine, but also embodied a powerful moral lesson. When Dr. Banting sold the patent for insulin for just $1. He said, insulin does not belong to me, it belongs to the world. That spirit of confession, of collaboration, and of shared responsibility continues to guide Canada's approach to diabetes today and inspiring everyone. In Canada, diabetes affects nearly 1 in 10 Canadians. And pre-diabetes, if I would say, I'm from Brampton, every 5th or 6th Bramptonian are affected with the pre-diabetes. Every day, more than 600 people are newly diagnosed. Behind each of these numbers is a person, a family, navigate daily challenges that touch every part of life. Even though when I was talking to, in the morning when we were coming to the Parliament, I was watching General Secretary Sana, who was struggling yesterday when she was giving speech, and her husband, Asim, thank you so much. We need a family support too, who was fighting with diabetes. Without family support, the person cannot be successful, because family involvement is very, very important too. And mental health, and previous speakers talking about mental health is also impacted very, very much. We need to talk about that more on that too. Diabetes affects people in every region, every age group, and every background. When I went to my hospital, there was yesterday, I shared 22 machines were running day in, day out. They are not saying, they're saying that what age they are doing the dialysis. The main cause, mostly patients, was the gateway was the diabetes. For me, this issue is deeply personal. Before entering public life, I worked for years in healthcare, where I met countless patients managing diabetes, struggling to afford medications, and navigating system that was not designed around their needs. Those stories stayed with me. And when I was elected to Parliament in Canada in 2015, first time, I made a promise to bring their voices to the national level and to make diabetes a national priority. In 2015, I introduced a parliamentary motion to establish November as a Diabetes Awareness Month in Canada, because, Mr. Speaker, we have a lottery system. I have 199 number. I know that, if I bring the Parliament private member bill, I cannot be successful, so then I turn it to the motion, November as a Diabetes Awareness Month in Canada, ensuring that every year Parliament and Canadian would take time to reflect, learn, and take action on this chronic disease. That advocacy led to one of the proudest moments of my career, introducing my private member's bill, an act to establish a national framework for diabetes in Canada. Through this legislation, I worked to ensure that diabetes was treated not as a partisan issue, but as a national health priority. In 2021, that bill became a law that Canada officially adopt its first ever national framework for diabetes. The framework is a roadmap for action built through extensive consultation with provinces, territories, researchers, health advocates, and most importantly, people living with the diabetes. It focuses on our 4 key pillars. First, awareness, prevention, and health promotion, tackling the root causes of diabetes through healthy living, education, and nutrition programs. Mr. Speaker, you are early when you're saying it's important to healthy eating, sugary drink. That is very, very important. And the second is active lifestyle. It's also very important. And my bill, access to the equity, ensuring that every Canadian, regardless of where they live, how much they earn, can access the care medications and technology that need. Dr. Jackie, you are talking about the access. This is something, every legislature, when they are bringing the bill in their country, they should know, the access is very, very important. Research and innovation, supporting Canadian scientists and institutions who are driving advance in prevention, treatment, and technology. I would proudly say from 2015 till now, almost $287 million were invested in research so we can find the cure. And there's so many scientists are working so hard on stem cells, Edmonton Protocol, and 20 teams still working so hard so we can find the cure of diabetes. Awareness and stigma reduction, promoting understanding, this is a fourth pillar because stigma reduction is very, very important. Promoting understanding and inclusion so that people with diabetes are never judged or marginalized. This framework was not just a policy document, it was a national call for action. It gave direction to governments, researchers, and healthcare providers to work together towards a common goal, improving outcomes and quality of life for every person living with diabetes in Canada. In the years since its adoption, Canada has taken major steps to put that framework into practice. Since 2015, Canada has also made major investment in diabetes research, including the data sharing. I was pleased to championing, when we are working in the data sharing, it is important. When we don't share data, it is not for the global community, it's hard, as Dr. Jackie said that, and because data sharing is very, very important to make the policy. Across our country, dedicated medical teams and scientists are exploring stem cell-based therapies, next-generation insulin delivery, and prevention strategies. In 2024, the Canadian federal government announced the first phase of Canada's National Pharmacare Initiative, a historic step towards universal access to prescription medication. Provinces has to sign bilateral agreement because in Canada, healthcare delivery comes from provincial jurisdictions. Under this new program, when the provinces signs it, all Canadians will soon have free access to essential diabetes medication and supplies, including insulin and glucose monitoring equipment. This progress reflects a simple but powerful belief that no one should suffer because they cannot afford the medicine they need. Canada's work does not stop at our borders. Diabetes is a global challenge that requires global solutions. We are proud to collaborate with the World Health Organization through the Global Diabetes Compact and with the International Diabetes Federation and Parliament Diabetes Global Network to share data, best practice, and policy tools. Our researchers continue to advance new frontiers, from artificial pancreas technology to indigenous-led diabetes prevention models, demonstrating how national action can drive global innovation. We also recognize the importance of sustainable data collection, and we are investing in better national surveillance and digital health systems to track outcomes and inform future policies. By working together across government, continents, and disciplines, we can accelerate progress for everyone. I think of the young child newly diagnosed, learning how to live with this disease. I think of the parent balancing work, family, and endless medical appointments. I think about a young player, partially blind with diabetes, and how he can lead the life. And I think of the seniors of my own community of Brampton and across Canada managing diabetes while living on fixed incomes. Their resilience inspires me every day to work more. And it reminds me why this fight is not about politics, it is about people's lives. Friends and colleagues, a century ago, Dr. Frederick Banting and his team gave the world the gift of insulin. And with this hope, in my home country of Canada, it's a historic Banting House. Outside the Banting House, there's a fire, a flame of hope, and it is shining. It only extinguishes when we find a cure one day. That flame reminds us that our work is not done, and that together, through science, compassion, and global partnership, will keep that flame burning bright until the world no longer needs it. Today, our duty is to honor that legacy by ensuring that hope is not limited by geography, by income, or by circumstances. Let us continue this work together so that one day future generation will look back on us and say, this was the generation that changed the story of diabetes forever. And Ms. Baroness May, thank you for moving the needle in Europe. We need more person like you so we can make a history. I know in Canada, we have a group of people who is working hard, but we need more. And today we are all inspiring each other. And let's make a commitment. So when we are going back to the country, we can work more. And one day, we can lead the way for the future generation. Thank you very much.
Thank you very much, Honorable Sonia Sitchfield from Canada. I invite any remark or question to the speaker. Yeah, you got the floor.
Thank you to the honorable member. My name is Emma Clateman, and I represent Life for a Child, a global program supporting over 60,000 young people living with type 1 diabetes in low and middle income countries. I've also been living with type 1 diabetes for almost at the 30-year mark, so it's hard to remember life, any other life that I had before diabetes. And in those 30 years, I've been an advocate. And one thing that I've learned after all of this time is that advocacy is not just for advocates. Advocacy is not just for people living with diabetes. And I'd just like to thank every member of Parliament here for being an ally. It is so helpful to this marathon, so thank you.
Thank you.
Thank you very much for sharing your opinion. And I think, type 1 diabetes, when one young child, in the school, they don't know how to manage their diabetes. That is why I just really want to, I have some copies to see that, how we can, how we can manage the diabetes. So untreated diabetes have serious consequences. So before it turns into the serious consequences, we can manage the diabetes and live a happy life. So this is something we all should do. And because when you are going to the diabetes journey, and this is something, of course, when I said mental health, and there's more, the child, but there's a stigma around there. So that is why, thank you for sharing. Let's work together. I tried to put everything in this bill, but one thing I just want to tell all the parliamentarians in this bill, I said after 5 years, because the world is changing, after 5 years, we can revisit this bill. So whatever need to be changed, we can change it to so Parliament gave back to the result after 5 years. What need to be changed, we can change that. Thank you.
Thank you very much. We can continue on with our program. Now we have the participation of Parliament itself. So I call two members of Parliament. The first I call Honourable Romilda Zab. She's the chairperson of the Parliamentary Committee on Health. You've got the floor.
Honourable Speaker, esteemed members of Parliament, distinguished guests, ladies and gentlemen, it is both an honour as well as a responsibility to address the House today during this Global Parliamentary Forum being set here in Malta. I would like to present you during these minutes with an update on one of the most significant public health challenges of our time, diabetes, and the continued development of our national diabetes strategy. Diabetes, as we all know, is a chronic condition that touches many of us, whether we live with it ourselves or else, for sure, we know someone who does. In Malta, we have more than 46,000 people already living with diabetes, a figure that may sound like just another number. However, it carries a much deeper meaning to us. Behind it are our colleagues, are our friends, our families, our loved ones. We heard this morning, even our children. For Malta, this figure means that nearly 9% of our population is affected by this chronic condition. And to give a little context, we have around 34,000 people that are aged over 60 suffering from diabetes. 9,000 people are aged between 40 and 60. 2,500 people are aged between 18 and 40. And then we also have 290 people that are aged under 18 years. Compared to other EU countries, we have the fourth highest age standardized prevalence rate. According to OECD, in 2021, Malta had the third highest mortality rate attributable to diabetes in the EU. This was not just a statistic for us. This was a call for action. We launched Malta's first national diabetes strategy back in 2015, and since then we have made significant progress in transforming diabetes care, prevention, and management. Through this strategy, we have embraced an integrated, patient-centered approach that is one that supports individuals across their life course, from health promotion and disease prevention in schools to advanced clinical care in our hospitals. Various health promotion campaigns and services have been launched to control obesity, which is one of the major risk factors for diabetes. National programs have been launched with the aim of promoting physical activity as part of this collective effort to build a more healthier population. We have even gone a further step, and we have taken legislative measures regulating food in school canteens, which was important. Education and empowerment remain central pillars of our work. The Diabetes Education Unit at Mater Dei Hospital delivers numerous education sessions for persons living with diabetes every year, while nurse-led diabetes clinics continue to grow in attendance, and this is reflecting the community's trust in these services. Among our proudest achievements under the strategy is the universal rollout of continuous glucose monitors for all persons living with type 1 diabetes. This was a first for our country, a landmark step that has empowered persons living with diabetes through technology and improved their quality of life by providing them with the necessary tools to manage their own health within their homes. This initiative has given persons living with diabetes and their caregivers more peace of mind, especially during the nights. It has also allowed them the possibility to carry out basic activities, which we tend to take for granted, like attending school outings without the need to have a parent accompanying the child and also using school transport. For persons living with diabetes who are 24 years and younger, we have also provided them with the service of remote patient monitoring, where a call center alerts persons living with diabetes or their relatives through a phone call when their blood glucose level is out of range. By providing persons living with diabetes the possibility to monitor their own glucose levels in real time, without the need for multiple pinpricks, and giving them the necessary education to self-manage, we have equipped persons living with diabetes with the necessary skills and tools to better stabilize their blood glucose level, thus reducing the need for recurrent hospital admissions and reducing also the early onset of complications related to diabetes. Through primary healthcare system, we inaugurated the Diabetes Clinic in Ormi, where persons living with diabetes are cared for by a multidisciplinary team adopting a holistic approach, all under one roof. The service is built around persons living with diabetes and their needs, making it easier for them to attend appointments and access diabetes care. In Gozo, the diabetes clinic is at the Victoria Health Centre. Thus, care is being brought closer to home. These advances are producing tangible results. More persons living with diabetes are being monitored and are achieving better glycemic control while also receiving the multidisciplinary support they all need. We also acknowledge the importance of supporting young people living with diabetes as they move from pediatric to adult services, ensuring continuity of care through the establishment of a transition clinic. This is a delicate and important time in a young person's life, when adolescents start to take a greater responsibility for their own health. By supporting persons living with diabetes who are undergoing this transition, we are ensuring that no young person feels left behind and that every individual continues to receive the guidance, the compassion, and the expertise they need to thrive into adulthood. Our government formulary list also has been expanded to include several new and effective treatments. At the same time, we have strengthened specialized diabetes services, opening a diabetic food ward in Mater Dei Hospital and a food clinic in the community in Birkirkara. Our national screening program for diabetic retinopathy ensures that persons living with diabetes have access to eye screening, while podiatric clinics play a vital role in reducing severe complications, including amputations. At hospital level, multidisciplinary diabetes care teams deliver comprehensive inpatient and also outpatient services, mitigating the complications and improving the outcomes. The financial burden of diabetes is important to take into consideration. According to the International Diabetes Federation's Diabetes Atlas in 2024, it was estimated that over 117 million euros were spent on direct health expenditure on diabetes in Malta. Beyond the financial impact, there is the human cost, the psychological strain, the stigmatization, the issues with insurance companies, the higher rates of depression, and the reduced quality of life that so many people with diabetes continue to experience. We salute the commitment of our healthcare professionals, patient organizations, and policymakers who have driven progress over the past decade. Yet, we are fully aware that Malta's diabetes epidemic requires sustained, coordinated, and collaborative efforts across every sector of society. This government remains steadfast in its commitment to prevention, early diagnosis, and state-of-the-art treatment so that every person living with diabetes may live longer, healthier, and with dignity. As we look ahead, the updated National Diabetes Strategy builds on the achievements and lessons of the past 10 years. It will strengthen our focus on earlier diagnosis, the creation of a national diabetes register, and the continued expansion of accessible community-based care. We are proud of how Malta has come, but we remain clear-eyed that there is still more to be done. Every person living with diabetes deserves the chance to lead a full and dignified life, and this government will continue to work to make that a reality through prevention, through innovation, through the highest standards of care. International fora play a crucial role in raising global awareness and in driving policy action to prevent and treat diabetes. They also help put pressure on governments worldwide to reduce the inequalities that persist between countries. Together as politicians, policymakers, health professionals and citizens, through collaborated national and international efforts, we will continue to reduce the burden of diabetes and build a healthier, stronger and more hopeful future for our nation. All these efforts stand to show how the government is committed to tackle the challenges posed by diabetes head-on by investing in prevention, early screening and stronger chronic disease management systems. These are not isolated initiatives. Together, they form a national system of care that is patient-centered, equitable, and forward-looking, Nevertheless, the fight against diabetes
Can you
is
conclude,
far
please?
from over. Mr. Speaker, this government recognizes that diabetes is not only a medical condition, but also a social and economic challenge. This is why we are addressing its root causes through interministerial collaboration and community-based actions. Thank you all for your attention.
Thank you very much, Honourable Romilda Garg. Now I invite Honourable Stephen Spiteri, who is the official spokesman for health for the opposition. You got the floor.
Thank you, Honourable Mr. Speaker, for hosting us here in our beautiful Parliament. Thanks to Baroness Theresa May for setting a number of examples, helping us reduce the stigma related to diabetes. Because actually we still have stigma, especially at the workplace, with individuals who suffer from the condition. Suggesting an answer to one of the questions related to accessibility to technology, I think we must convince our finance ministers that achieving normoglycemia in individuals with diabetes will prevent long-term complications, and this will definitely reduce the cost on our health budgets. The prevalence of diabetes in Malta is quite high. It is, in fact, one of the highest in Europe. Approximately 1 in 10 are diabetic in our country, and it's expected to increase. This high prevalence makes diabetes a national public health priority, necessitating strategies for prevention, early diagnosis, and management. Type 2 diabetes accounts for over 90% of our cases. Considering the association of diabetes with these predisposing factors enables us as politicians to formulate our policies and decisions targeting the main objectives: prevention, screening, and management. Preventing long-term complications related to uncontrolled diabetes is a priority in healthcare. This reduces the impact on secondary care, which is more complicated for the patient and the treating professionals, but also more costly on the national health budget. I am going to highlight important issues in diabetic management and some policy recommendations. Barriers to annual diabetes screening and follow-up. Many patients, especially elderly, fail to attend annual diabetic checkups and screenings. Contributing factors may be cognitive decline and forgetfulness, stigma and fear of poor results, limited mobility in our elderly. So some recommendations will include implementing reminder systems, providing community-based transport, and launching of public awareness campaigns explaining the importance and consequences of non-attendance. Psychological health and diabetes. Depression is a major underdiagnosed complication of diabetes which affects the patient themselves. Lack of funded annual psychiatric evaluation for diabetic patients may be a contributing factor. So, introducing free annual psychological assessments for diabetic patients as part of the National Diabetes Care Pathway would greatly help. Nutrition and exercise is crucial, as discussed previously. Poor nutrition and sedentary lifestyles contribute to diabetes onset and progression. Government recently introduced and launched the new Care for You Diabetes as an initiative focusing on type 2 diabetes management through multidisciplinary approach involving lifestyle intervention. Policy recommendations include employing more nutritional consultants across the care for diabetic patients, and an integrated community-based physical activity programs targeting high-risk groups. Fiscal policies to promote healthy eating. Eating right is a powerful tool in the management of diabetes. Education has to start early from primary level through secondary and tertiary with a different approach according to the age groups. Implementation of higher taxation, as Mr. Speaker suggested, on foods high in sugars and saturated fats, and providing subsidies for healthier alternatives such as fruits, vegetables, fish and white meats, and promoting public education campaigns on the economic and health benefits of healthy eating. It's very important that a shared approach between primary care and secondary care is adopted. Linking primary care involves a direct approach between the patient and the physician, or the nurse or the paramedic involved. This personalized care instills more confidence, especially when family medical practitioners are engaged. Investing in programs where private GPs are involved will definitely help. Follow-up of mothers with impaired glucose tolerance and gestational diabetes is also crucial, as you suggested, because we can decrease the incidence in this cohort. Screening for high-risk populations, individuals with non-communicable diseases like hypertension, cardiovascular disease, which have a higher risk of developing diabetes. Implementing enhanced and more frequent diabetic screening in these age groups will also help reducing the incidence and complications. Dietary habits in the elderly population. We have the privilege of having a very good type of bread in Malta, the hobza, and we have to help in reducing its consumption because it's full of carbohydrates, and so encouraging the formulation of our traditional foods using healthier ingredients, launching of educational campaigns in promoting portion control and a balanced diet. Patient complaints regarding changes in formulary drugs, for example, from one type to another, can affect their glycemic control, and implementing a feedback and pharmacovigilance mechanism to monitor patient outcomes after medication substitution is also crucial in the management, especially in the elderly, and engaging clinicians and pharmacists in a transparent communication mechanism regarding formulary decisions. Low medication literacy and complex treatment regimens contribute to poor adherence and higher rates of diabetes-related complications. Providing each patient with a personalized, easy-to-understand medication chart outlining drug name, dosages, and timing is also important. Ensuring this information upon hospital discharge or following primary care visit. Introducing a government-funded initiative to distribute free pill boxes to pensioners and to support adherence and minimize medication errors avoids some gross mistakes, which I have a personal experience with my patients. Integrated pharmacist-led counseling sessions to improve adherence, understanding of therapy, and self-management skills is important. Important that the pharmacist is involved in diabetes screening, and a doctor-patient-pharmacist relationship is adopted in managing these patients. In conclusion, diabetes is a global pandemic that requires a united front. This will strengthen our forces in preventing and reducing the incidence of diabetes. It will enable us also to manage the short and long-term challenges, thus offering a better quality of life to those affected, but also a healthier society. Thank you very much.
Thank you very much, Honourable Stephen Kateri. Before I give the floor to close this important conference to Sir Michael Hurst, I want to thank you all for your contribution to this important special parliamentary session. I would thank you, Baroness May, for your presence, not only presence, and your important delivery and questions that you had to answer in this particular session. Definitely we need to do more. We need to do more and more. And I'm sure that every one of you agree, as also in his conclusion, Professor Gallia mentioned the United Nations, of course. The role of Parliament all over the world is imperative in order to make sure that the issue of diabetics, where legislation reform is concerned, has to play its part. I thank you all. Now I give the floor to Sir Michael Hurst to conclude, to make your conclusion. You got the floor.
Well, Mr. Speaker, may I reiterate my thanks on behalf of all the parliamentarians for your welcome here today, for enabling us to enjoy the atmosphere of Malta's unique parliament. Thank you for your personal kindness, and also may I thank your staff for their liaison with Chris Delicata over recent months. They have been endlessly helpful, and we're very grateful indeed for that. The coaches will be taking us back to the hotel where lunch is served on level 4, I beg your pardon, on level 4 buffet, and the forum will resume in the Floriana suite at 2 o'clock. Thank you very much, Mr. Speaker.
Thank you. I invite you all to come over forward to have a group photo.